Hey everyone, welcome back to Phlebotomy. Today we are going to cover Chapter 10, Capillary Puncture Equipment, Principles and Procedures. This chapter we are going to discuss the objectives of the chapter. This is the objectives. We are going to define and use capillary puncture terminology. We are going to identify the equipment used in capillary puncture. You're going to list the order of draw for the capillary specimens and also the theory behind it, why we draw those in that order. You are also going to describe the capillary specimen composition, which means we are going to be able to tell the differences between capillary, arterial, and venous composition, and also some reference values. We're going to discuss when a capillary puncture is indicated, when it is okay to do it, and also the site of where you do it at. We will name the tests that cannot be done on capillary specimens and why those cannot be done. We will describe how to collect these specimens from infants, adults, and children. We will also describe specimen collection procedures and explain the significance of capillary blood gas, neonatal bilirubin, and newborn screening test. We will also describe how to prepare both routine and thick blood smears from a capillary stick and give the reasons why they are sometimes made at the collection site when you stick the patient. And we will identify the tests performed on them. And then lastly, we will discuss any complications of capillary puncture. So let's begin here with the capillary puncture equipment. First, you will have lancets or some type of device that you stick the finger or the heel stick if it's a baby with. These will be sterile, disposable, sharp pointed, or have a little tiny blade on them. You will throw these away in the sharps containers just like we do with the needles. These devices will make a puncture or a tiny little cut on the skin, and that is what gives you the capillary blood specimen. So you will do these either on fingers, or if it is a newborn, you will do it on a heel puncture. Now there are different types of lancets. This is a picture of some finger puncture lancets. So you can see they have different colors there. These are also different types. These are different companies. And so if you are looking in your book, you can look, it starts on 353 and goes to 354. It discusses the different types of lancets. But basically what they are is they are designed for a one-time use only. So if you stick somebody with that lancet, you can't re-stick them with the same lancet. You're going to do it one time because they have these sterile blades or those points on them. And so even if like your lancet misfires or it does not actually puncture the skin, like if you don't do it correctly, you still can't use it again because that means that it released that blade out. And so you're not going to be able to do that again. They do have a range of lengths and depths so that you can have different types of specimen collections from those. But the selection depends on how old the patient is, the site that you are collecting from, how much volume that you're trying to get from that specimen collection. Like, are you trying to get just one microtainer or do we want to get several? And also the puncture depth that to get an accurate specimen. You want to get an accurate specimen, but you don't want to actually get a lancet that will stick them to the bone. because then you have a risk. Not only does that hurt, but you have a risk of them then having a bone infection potential from using the wrong size lancet. So you've got some lancets that are specifically for finger punctures, and they are in this slide here. Then you have lancets that are specifically for infant heel punctures, and they are on this slide. So you can see how these are square shaped. So you also have a preemie version. That preemie version is the one that in this particular picture, you can see it's in the greenish color on A. And then look over on the B side, you have tenderfoot, that is the pink, that's for a toddler. You have the blue and pink, that is for a newborn. You have the white, and that is for a preemie. And then if you have a micro preemie, which is the teeny tiniest babies, then those are the solid blue ones. And so if you end up working in a women's center, hospital, or something, you will need to learn about these different colors for sure, so that you don't use the wrong size lancet on those babies. Okay, another part of the capillary puncture equipment is, well, what kind of containers do we use to collect this specimen? We use microtainers. So microtainers only collect a tiny small amount of blood. So after you do the capillary puncture, this is what you are going to use. This is the micro containers that you actually use, and they call them micro tubes too. So what they do is you can collect tiny amounts of blood from that capillary puncture. Sometimes they refer to them as bullets because of their size and shape, but they come fitted with a little bitty plastic capillary tube to facilitate and help you with the specimen collection. But some of them don't have that, or they have this scoop or funnel to assist you with the blood collection. So let me show you on the next slide those. But basically what you're looking at here in this particular picture is this is an example of what a microtainer would look like, and you can see the different amounts. You see the 250, 375, and 500. Those are the different amounts. If you keep collecting the blood droplets, that's how far you can go up there. They do have color-coded stoppers, and they have the minimum and maximum fill levels. So depending on which one you use, you need to be aware of how much you need, and also which colors of these capillary tubes you need, depending on what the tests are. These are especially good for pediatric patients that we don't want to get a lot of blood on, and also when you don't have to have a lot of blood. Like if, say, somebody is a pretty hard stick and maybe the doctor only ordered one test, and in that case you could, but if possible, a venipuncture is always best. But they do have to have these color-coded tops, and those correspond to the color coding in the evacuated tube system. In the double-headed needle that we've practiced and you've seen, that is the color-coded top colors that you still go by. So they're the same colors for what is in those tubes. They also have the markings on them. Okay, they are typically measured in microliters. So those numbers like 250, 375, 500, those are microliters. Some of them have the lot numbers on the actual tube, but they will also have expiration dates on each tube. So this depends kind of on the manufacturer. Sometimes they put that on the box, but sometimes they have them on the individual tubes. Okay. If you look at the caution in your book, it's on page 355. This is something that you need to be aware of that sometimes people do. If you collect a very small amount of venous blood by a syringe, like say you're drawing a patient and they are a hard stick and you get just a little bit of blood, but that's it, you don't get much else, so you don't get enough for that big tube. If you get just a little bit in that syringe, now I'm not talking about if you use the evacuated tube system, like if you're putting the tube on there, you can't take what's in the tube and pour it into this. But I'm saying if you draw it from a syringe, if it's a difficult draw and it's in a syringe, sometimes you can take what's in that syringe and put it in this microtube. But it must not, and pay attention to that, it must not be done unless the microtube manufacturer supports that. So if you're using microtainers for venous blood, if it is allowed, then this specimen needs to be labeled as venous blood, not letting the lab think that this is capillary blood, because otherwise they will think that you did a finger stick or maybe a heel stick. And if they're doing that, sometimes the levels of whatever you're measuring vary. You need to make sure that you write on that specimen somewhere that this is venous blood, because otherwise these values are going to be out if you put venous blood in a micro container. Okay, so make sure that you are very aware of that. There's going to be lots of problems if you don't label that. But also just don't do it unless the actual manufacturer states that it can be done. And again, you can't take it from another big tube and pour it into the little tube, because then you have already messed up how much of the anticoagulant that is in the big tube. You're pouring it in a little tube and all of the percentages are off now. Okay, so let's move along. Next, you have micro hematocrit tubes and sealants. So these are little disposable, narrow, they can be plastic clad little, or they can be all plastic or plastic coated with, glass coated with plastic. But what this does is, still, after you do the capillary stick using the lancet, you can feel this by capillary action, and it will hold anywhere from 50 to 75 microliters of blood. You are going to use these primarily for hematocrit determinations. So make sure you know HCT, that stands for hematocrit. This is part of a complete blood count. And you can do a manual, what they call a manual hematocrit with this. This is also called packed cell volume. So make sure you know that. Hematocrit is also called packed cell volume, or PCV. So what these tubes are coated with ammonium or sodium heparin for collecting these hematocrits directly from a capillary puncture. This is to be used when a hematocrit is prepared using blood from a purple top. Okay, so you can do that from a purple top tube. Heparin tubes usually have the red or the green band on one end, so you can see how in this picture those little tubes have the little blue stripes around them. And then what they do from there is they spin it down in what we call a microcentrifuge. It spins that blood down, and then you measure it out to see what their hematocrit is based off of that. This is like a little chart that you're looking at. Okay, capillary blood gas equipment. Let's discuss this for a minute. This is obviously used for what it says, capillary blood gases. Usually the collection tubes are long, thin, narrow little capillary tubes. They're plastic, usually for safety. They do have different sizes for different volumes for different pieces of equipment. But the most common is 100 millimeters long and it holds 100 microliters. So inside of this tube is heparin. This is a green band around the edges of this. Okay, so you're going to get that green band on the tube. Okay, microscope slides. These are used for blood films and hematology. So occasionally you will make a blood film, and in that case, when you make it, then the lab gets the slide and they do a manual count on the white and red cells inside of that slide that you do. Another type device is a warming device. Make sure somewhere that you document that the main reason we're going to use warming devices is if you are doing a heel puncture on a newborn. Okay, a heel puncture on a newborn. If you are looking in your book, you can look on page 357, figure 10.6. That is a picture of an infant heel warmer. So these are made by a manufacturer. You want to make sure that the device does not exceed 42 degrees Celsius. If you don't have one of these man-made devices, you can also use a towel or even a diaper that has warm tap water on it, and you can take that warm tap water, run that over that towel or that diaper, squeeze it out, and put the warm towel on their heel, okay? You can also put it on somebody's hand if their fingers are not easy to stick. If they're really cold, then you are not going to get good blood flow. So if that case, you want to make sure that they can also rub their hands together and warm them up and get some blood flow going there. You just want to make sure if you're using water and not a commercially made heel warmer, that you don't get the water so hot that it scalds the person. But basically what this does is increase the blood flow up to 7 times, which makes their blood come out a lot better for you when you're trying to collect it. All right, this is just an up-close picture of the capillary blood gas collection equipment. You've also got the little caps that go on the end, the blood gas syringes. All of that is all what you would use for that capillary blood gas. Okay, now let's discuss the capillary puncture principles. Capillaries are just tiny little vessels, and just you have to remember this. Capillaries connect arterial and venous blood. I know that is on your exam, so make sure you know that. Capillaries connect arterial and venous blood. And where this exchange of gases and nutrients takes place, that is a capillary, where the venous and the arterial blood connect. So the capillary bed is where the capillaries that supply the blood to a specific area of the body, for example, like the fingertips or the heels in the babies, this is the determining factor of where we are going to get our specimen from. Capillary blood, though, it is not the same as venous blood, and it is not an acceptable specimen for some tests. Also, capillary puncture is not appropriate in certain situations, but when it is an acceptable alternative to a venous specimen, then you need to make note that this is, like, for example, when I was telling you a minute ago, if you draw a little bit out of a syringe, you use that blood in a microtainer, you want to make sure and note that it is venous blood, because again, the big deal is that the reference ranges in the lab are going to be different. Okay, one thing I want you to make note of too is on page 357 in your book, there's an FYI. The FYI is important because it talks about the capillary bed. This is how you can kind of see. If you press on your fingernail and it doesn't have nail polish on it, notice how it turns white, because that means the blood flow is cut off when it turns white. When you squeeze on it, it cuts it off. When you release it, it immediately turns back pinky color again, okay? And that's why your blood flow is returning. This reaction is sometimes used to assess the health of the circulatory system. Now, you can't do that if someone has nail polish on. If the time it takes for the blood to return to the nail is prolonged, this can indicate a circulatory system problem. Have you noticed that, like, if you go to surgeries and things, they ask that you have no nail polish on? That is just one reason why. That's one of the ways that they can kind of look if there's an issue going. Okay, so let's talk about some puncture risks. Some of the risks are bruising, hematomas, possible infection, puncture site calcification, and scarring. Okay, also let's talk about the composition of these specimens. We already said that it is a mixture of arterial and venous blood. So capillary blood, along with the interstitial fluid, you need to know what the interstitial fluid is. Interstitial fluid is the fluid from the spaces between the cells. Okay, so that's spaces between the cells. Then intracellular fluid is the fluid within the cells. Think about intra is in there, and then cellular means cells. So those are going to be all around in that area too. So the arterial blood is going to enter the capillaries under greater pressure than the venous blood will. So capillary blood is automatically going to be a higher portion of arterial blood than venous blood. So even though it is a mixture of the two, it is higher in arterial than venous. This is especially true if the area has been warmed, because warming increases arterial flow into that area. So the reason why the composition is important is because when you stick somebody's finger, you are not just getting that capillary blood. That's not all there is. There is also interstitial and intercellular fluid mixed in there. This is one of the reasons why when we stick the first drop that comes out, we are going to wipe it away, because that drop has a lot of tissue fluid in it. We are going to then collect every drop after that. Okay? The reference values. Capillary reference values differ from venous values. Remember when we discussed reference values, these are where we get our norms and what the average ranges are for people in that area. So these are going to be different from if you did somebody through a vein, if you stuck somebody through a vein. Some very important ones that you need to keep in mind. Now, most of them are pretty minor, but some that are important that you need to keep in mind are glucose. Glucose concentrations are higher in capillary blood than they are venous blood. So if you have a diabetic that is being stuck regularly and you're doing venipunctures on them every day, and then all of a sudden you do a finger stick, you need to keep in mind and also make note in the lab if you do a point of care testing where you stick them at the bedside. If the result goes across, they should automatically know this is a point of care test, so this means it is capillary. But if there is a place where you are to document anything, then you do need to document that this was a capillary stick, not a venous stick, just so that they know to not be aware of the differences in the values over the days. Okay, some other ones that you do also need to know that is important: bilirubin, calcium, chloride, sodium, and total protein. Those are all lower in capillary blood, and you do need to know these tests, okay? Bilirubin, calcium, chloride, sodium, and total protein. They are lower in capillary blood than they are venous blood, okay? One that is not on here that you need to add is capillary hemoglobin and hematocrit values on a 1-day-old newborn. Those are going to be up to 12% higher than venous blood values. So if you have a newborn baby that you did a heel stick on, their hemoglobin and hematocrit are going to be up to 12% higher than venous blood values. One other thing to keep in mind is that if you don't wipe off that first drop and then collect the rest, if you are doing a potassium may be falsely elevated if there is tissue fluid contamination or if you have a hemolyzed capillary specimen. And when I show you how to do capillary sticks, when we practice these, you are going to do what we call the milking technique. You're not going to squeeze their finger as hard as you can. You are going to try to gently milk it out like you'd milk a cow, because this way you are not going to hemolyze the blood if you are not squeezing so hard on their finger trying to get it out. Okay, older children and adults. So first of all, you need a properly collected specimen. And in order to do that, we have to decide when it's acceptable to use these capillary punctures, because these are some of the reasons how why you could do this, these certain circumstances. Any of these circumstances are going to be an appropriate reason that you could actually do a capillary puncture, and you need to know all of these. The available veins that they do have, if they have really tiny fragile veins, they're hard to get to, they know they're a hard stick, maybe they've already been stuck 2 or 3 times by somebody else, and maybe they need an IV and you're coming in there first, then you don't want to be the one to use up their one good vein that you can find, and if they don't need very much. So in that case, that's okay. If their venipunctures that maybe you or someone else have done have been unsuccessful, and whatever the doctor ordered can be done by capillary puncture, like let's say you've already stuck them in both arms, and maybe you've already looked at the hand veins, hopefully you haven't already stuck the hand veins too, then maybe then you can look and see if that test is acceptable by a capillary stick. And if so, you can do that and get enough blood. And that way you're not walking away empty-handed from that patient. Another reason that is acceptable is if your patient has lots of burns or scars. That will make it hard to get to their veins and painful if they're burns. If they have clot-forming tendencies. So again, if they are a thrombotic type patient, which has clots a lot, in this case, then you would do a capillary on them. If they are extremely apprehensive or needle phobic, they may be more comfortable with you doing a capillary stick. And if you can get the amount of blood that they need with the capillary stick, if they are just terrified, then you can do it if that's the case. If your patient is very overweight and their veins are very difficult to find, then this is acceptable. If they have no accessible veins, this means they got possibly IVs in both arms, maybe they have scars on one arm and an IV in the other, maybe they're burned all the way over, or maybe they have scars all over. Either way, if you don't have a good accessible vein, and just keep in mind, some of these things you can't do capillaries on, but if what the doctor has ordered is possible and they have no accessible veins, then yes, it is okay to do a capillary puncture. And then lastly, these are always done by capillary puncture. Point of care testing procedures. So know what that stands for, POCT. Point of care tests, okay? This is when you go to the bedside and you stick their finger to run like one little test. For example, glucose monitors. Okay, infants and young children. This is the preferred method, okay? These are small blood volumes, so this prevents them risking any type of anemia for too much blood being taken. Look at what's in parentheses. For every 10 milliliters of blood removed, up to 5 milligrams of iron is also removed. So then if you go in and draw their blood constantly, then you are going to put them into anemia. So in this case, this is why you don't want to do that. They've got such a small blood volume anyway. Okay, rapid removal of large quantities in these infants and young children. This can cause them to risk cardiac arrest. Venipuncture is difficult and may damage the veins and the surrounding tissues. Puncturing deep veins can cause hemorrhages, venous thrombosis, infection, and even gangrene if that infection were to take hold deeper in there. An infant or child can be injured by the restraining method that is used on these babies to be able to do the venipuncture if it's not done properly. Capillary blood is the preferred specimen for some tests, such as newborn screening. If you're looking at your book on page 358, you will see table 10.1. You do not have to memorize this, but I do want you to take a look at what would happen if you look at the implications of a 10 milliliter blood draw in an infant population. So look at the age, look at the weight, and look at the percent total blood volume that it would affect. So you can kind of look down and see. Of course, the younger the baby, the bigger the percent, because the younger the baby, the smaller their body, the less blood they have. Look at the caution in your textbook. It says capillary puncture is generally not appropriate for patients who are dehydrated or have poor circulation to their extremities from other causes, like if they are in shock, because sometimes they may be hard to obtain and may not be representative of the blood throughout their body. So you've got to keep that in mind also. Okay, tests that cannot be collected by capillary puncture. Most tests today can be done on little bitty small quantities of blood, and lots of different devices make this work, but occasionally you'll have some that cannot be done this way. These include most erythrocyte sedimentation methods. These are what we call ESRs. The ESR test is done on a whole blood sample, like a purple top, and they allow the blood cells to settle, and in this case, you need a large amount of blood for this to work. Coagulation studies that require plasma specimens, blood cultures, and any other tests that require large volumes of serum or plasma. These are the ones that cannot be done. So can't do sed rates, no coag, and blood cultures, and then anything else that's a lot. Okay, I do want you to keep this in mind. Although light blue top microtubes are available, even though you have them, they are not to be used for capillary blood specimens. These light blue microtubes, they are only to be used if you draw a venous blood sample with a syringe and you can't get but a very small amount from your patient. But you can't do a capillary stick into this light blue top. Even though we have a light blue microtube, you can't use it for capillary. Make sure you make note of that, okay? Only taking a small amount of blood from a syringe, putting it into the microtainer, will it work that way, okay? But you can't do it with a finger stick. Okay, the order of draw for collecting these samples for capillary is not the same as for venipuncture. So you need to keep this in mind. It is different. Puncturing the skin releases what we call tissue thromboplastin. And what that does is that activates the coagulation process in the blood. Okay, so specimens need to be collected quickly to minimize any kind of platelet clumping and microclot forming, to make sure that we get the specimen collected before the site stops bleeding. Sites that are most affected by clotting have to be collected, not sites, specimens, the tubes. The specimens that are most likely affected by the clotting need to be collected first. This is the CLSI recommended order of draw for capillary specimens, and this does take that clotting into consideration. So first is any blood gas specimens that you need. You want to minimize the air exposure, and these are usually collected totally separately and by themselves. But if they're not, then they are the first in the order of draw. Next, you have EDTA specimens. This is your purple top microtainer. These are affected by the clotting process, and if you get a clot, even one teeny tiny clot, it is unacceptable and must be recollected. And so after you do blood gas and purple top, then you do any other additive specimens, and then serum specimens. Serum specimens are supposed to clot. So those are okay to have a clot in them because they should. But any other specimens do not need a clot. Okay, look on the side of that slide. Potassium levels may be falsely elevated if there's tissue fluid or hemolysis. I said that on a different one, but there's your note. If you are collecting a newborn screening test, it should be collected separately and from a separate puncture site. You're not going to use the same site. You're going to use a whole different site. Okay, blood gas, purple, any other additives, and then serum. All right, the general capillary puncture steps. First, you're going to receive, review, and accession the test request. Once you get your request and gather up your supplies, you will go to where the patient is. Step 2, you will approach them, greet them happily, and identify the patient, just like you would with venipuncture. Step 3, though, you're going to change it up because you're going to explain this procedure and you're going to obtain their consent. Now again, if they throw their finger out there, that is them letting you know that yes, you have consent to stick my finger. You would have to explain that you're doing a finger stick rather than a venipuncture. Step 4, you're going to verify the collection requirements and identify any sensitivities, potential problems. Step 5, you're going to sanitize your hands and put on gloves. Notice what we do not need here. For a capillary stick, we do not need a tourniquet. On this slide, step 6, you're going to position the patient. If it is a finger puncture, their arm needs to be supported on a firm surface. Their hand needs to be extended palm up so that you can see. If it is a young child, they're going to be held in the lap of a parent or guardian. If that parent or guardian is capable of holding them still while you stick their finger, that's fine. Infant heel puncture, they're going to be supine with a foot lower than the torso. If it is a toddler, you are not going to grab just one finger, okay, because they're very wiggly and their fingers are really little. You're going to hold 3 or 4 of their fingers together. Are you going to stick 3 or 4 fingers? No. We are only going to stick one, but you hold them together at the same time so that you can get a little grip on their little bitty fingers. Step 7, select the puncture site. Make sure the skin is warm. It has a normal color. There's no scars in the fingertips or the heels. No cuts already there. No bruises, rashes, edema, which is swelling. Make sure there's no edema there in that area, infection, and they are not cyanotic. So look at the precautions in Table 10.2. This is on Table 360 in your book. This tells you everything that it just said and describes the rationale behind each. So I'm going to go over these, but these are not on the PowerPoint. They are in your textbook on Figure 10.2. So why do we not want to puncture a bruise site? Because bruises can be painful, and also the circulation is not accurate in that area. So that's going to negatively affect your specimen if you stick a bruise. Do not puncture infected sites. Why? Because sometimes you're going to risk spreading this infection, and that would be painful, and not to mention erroneous in some of the test results. Avoid cyanotic fingers or sites. Why? Because erroneous test results. Avoid sites with rashes, because you might get a potential negative reaction, like inflammation may be masked in this case. Avoid scarred sites and healed burns, because there may be problems puncturing it correctly and you may not get a good specimen. Avoid swollen sites or sites with edema. That's because excess tissue fluid from these sites can contaminate the specimen, and again, you would have erroneous results. Cyanotic, in case you're wondering, that means bluish in color, and that means there's a shortage of oxygen in the blood. So in this case, that would be why you would not want to stick that site. You also wouldn't get good blood flow in that area anyway. Okay, adults and older children, you're going to take the palmar surface, which is the underside or the grasping surface of your hand. You are going to take the palmar surface, the bottom of the distal segment, so that's the very end of their finger, and also whatever you got to do, remember which finger, middle finger or ring finger of non-dominant hand. So ask them which hand they write with, and then stick the other hand. You're also going to stick on that hand either the middle or the ring finger, and you're going to get in the central or the fleshy portion of that bottom distal segment. In infants, if it is a finger puncture, anywhere from the infant being 6 to 12 months of age, you have specific lancets. Remember, we are not going to use an adult lancet on a baby. And so you're going to use the correct lancet in order to stick them. If it is a heel puncture, it is the plantar surface on the medial or lateral edge so that you avoid bone damage. Why do we not get right there on the very back of the bone of the heel, on the very, very back? That's because you have a bone close to that surface, and babies do too. And in that case, you are going to get too close to that surface. Okay, I want you to look on page 361 in your book. There is a caution, and it says, finger punctures must not be performed on newborns because the distance from the skin surface to the bone, even in the thickest portion of the last segment of each finger, It varies from 1.2 to 2.2 millimeters, which means the bone could be easily injured. And the same thing goes for the very, very back side of their heel. You also don't want to stick back there. Okay, this is a cross section of a full-term infant's heel showing the lancet penetration depth to assess the capillary bed. So this is in figure 10.9 in your book, which is on page 362. This shows you, like a heel stick, what it would look like and how far you would go down. Okay, do you see where it says terms for you to define? These are words that you need to know. One is the posterior curvature. Posterior curvature is the back of the heel, okay? Calcaneus is the heel bone. That calcaneus bone, especially in smaller premature infants, may be as little as 2.4 millimeters below the skin surface on the plantar surface, which is the sole or the bottom of the heel, and half that distance at the posterior curvature. Okay, so punctures deeper than this can cause bone damage, but this is, in that heel, the best area for the primary blood supply. Two other words it says you need to know are osteomyelitis and osteochondritis. So the first one is osteomyelitis. This means if we were to give them a puncture site and we were to hit the bone, we can cause inflammation of the bone marrow and the adjacent bone, and that is osteomyelitis. Okay, osteobone and myelitis being that inflammation. If you have osteochondritis, that is inflammation of the bone and the cartilage, and that is due to an infection. Okay, this is figure 10.8 and 10.10 in your book. These are the recommended sites in the direction of the finger puncture and the heel puncture. So the shaded areas show you where you want to stick on the ring finger and the middle finger on the non-dominant hand. This shows you in that area what you want to stick. Notice you go across, like you stick that across the actual fingerprints. Okay, do you see how it says this and not this on those fingers? You want to stick across the fingerprints, not in the same direction as their fingerprints. Figure 10.10 on that infant foot. Remember, we don't get in that middle. You don't get the very, very bottom. You don't get the back. You're going to get the sides. So that shaded area shows you where it is safe to do a heel puncture at. Okay, the next step, step 8. Once you find the site, you're going to warm that site if you need to. That is figure 10.6 in your book. That is the manufactured infant heel warmer that I was telling you about. You can also use, remember, a warm wet towel or even a diaper that is under warm water if you don't have one of these. But if you lay these on that site, then for about 3 to 5 minutes, it's going to increase blood flow. So look at step 8. Warming increases the blood flow, and remember how much? Up to 7-fold. pH or blood gas specimens, and they are recommended for heel sticks. This is essential to be able to do those. pH or blood gases, use a heel warmer. If you're doing a heel stick, use a heel warmer. So you wrap it up 3 to 5 minutes with a warm, moist washcloth, towel, or diaper if you don't have one of these. and then that is going to increase your blood flow. Step 9, gather your supplies right next to you. You've already brought your cart where it needs to be. Now we're going to gather up exactly which tubes we need. So you make sure you got it all within reach of where your patient is going to be. You're also going to select the lancet you want to use according to the patient's age and how much blood needs to be collected. Step 10, you're going to clean and air dry the site. So you're going to clean it with an antiseptic. Most of the time, the same little alcohol towelettes that you use for a venipuncture. 70% alcohol, isopropyl alcohol. Allow it to air dry. Remember, we don't blow it, we don't wipe it. This maximizes the antiseptic action and prevents it from stinging them. And hemolysis. If you wipe them with an alcohol wipe and then immediately go to stick them and it's not dry, then this is going to cause hemolysis. It's going to lyse the red cells and cause hemolysis in your specimen from that alcohol. Step 11, prepare the equipment. Don your gloves, which means put them on if they are not already on. Prepare collection devices aseptically, like if you have to take anything out of the packages, don't lay it on the bed, put it where it needs to go. Verify lancet sterility by checking to see if the package is intact. Prepare your equipment in view of the adult patient. Let them see what you're doing. Step 12, grasp the finger or the heel firmly. Hold the lancet between your thumb and index finger of your dominant hand. If it is a finger stick, you're going to grasp the patient's middle or ring finger between your non-dominant thumb and index finger. We're going to practice these. Step 12, if it is a heel stick, you're going to grab the foot gently with the non-dominant hand. So you're going to use it like you would the finger in the adult. Step 13, position the lancet, which means place it flat against the skin in the appropriate area that you just cleaned with alcohol. Tell the patient or the parent or guardian it's fixing to be a stick, and then activate the release mechanism. Hold it to the skin while it activates, and it's going to trigger the puncture. As soon as you hit the trigger puncture, then you are going to remove the lancet and immediately discard it in the sharps container. Step 14, you're going to lower their finger or the heel if it's the baby, and you are going to apply gentle pressure until a blood drop forms. Why are you wanting to do this down? You're going to downward position encourages the blood to keep flowing downward to allow you to get a good specimen. Step 15, we are going to wipe away the first blood drop. Why? You need to know why. Because it is typically contaminated with tissue fluid, and it also may have a little bit of alcohol residue on it. So once that first drop comes up, wipe it off. Then you are going to start collecting every drop after that. So step 16, fill and mix the tubes. Make sure you're going in the order of draw. Collect the slides if you're doing a slide. Platelet counts and other hematology specimens first to avoid any clumping and clotting. Okay, so collect slides, platelets, and anything hematology, so anything in that purple top first. Then collect any other anticoagulant containers, and your serum specimens are last, like your red and yellows are last. You're going to touch your collection tube or device to the drop of blood, and look at the caution. Do not squeeze. If you squeeze, you have a risk of hemolyzing that sample and making the patient get a recollect. You're going to use strong repetitive pressure, or this is where I was talking about the milking technique, okay? Because the blood comes a lot smoother if you do pressure, just strong pressure using a milking technique. Step 17, once you're finished, once you've got all the specimens you need, place the gauze on top of the finger or the heel, apply the pressure. We've got the finger down or the heel down now, remember, because we're sticking and blood flow's coming easy. So now you're going to raise that side up. Don't leave it down anymore, pick it up. Step 18, label your specimen, confirm the labeling information, prepare the specimen for handling and transport, and then take back to the lab if that's you that takes it back. Step 19, check the site and apply the bandage. So right before you leave the patient, there is a thing you need to make sure of. Look at the caution. This is a test question. Do not apply Band-Aids or any kind of bandage to infants and children younger than 2 years of age. And you need to know why. Because they pose a choking hazard, because they still put lots of things in their mouth. In addition, bandage adhesive can stick to their paper-thin skin of those newborns, and it can just tear it when they take the Band-Aid off. Do not apply self-adhesive stretchable gauze because it can roll up and it can cause like a tourniquet effect, which means that then, if nobody's paying attention, it can cut off blood flow to that particular area because when they wiggle around, it can roll up like a tourniquet and get tighter and tighter. Step 20, discard your used materials. Thank your patient for allowing them to do this, or the parent or the guardian if it is a child or a baby, and dismiss your outpatients. If they came to you to be stuck, you can then, when you're finished labeling and everything, you can say you're free to go. Step 21, remove and discard your gloves, sanitize your own hands. Step 22 is where we've already prepared it. Now we are ready to take the specimen to the lab promptly. Okay? So looking over these procedures in the book, these are the ones like we're going to do a finger stick procedure in class and we're going to practice. This is in 10.1 in your textbook. Let me see what page that is on. That is on starting on page 366 it's 366 to 370. Okay, so make sure you look over those. We are going to do those in class. They are going over the exact same steps that I discussed with you on how to do it, but make sure you look over that because we will stick in class next week. Heel stick procedure. This is in procedure 10.2. We are not going to go stick babies for practice, but I do have a little heel that I can show you how to hold in class so you can know how to hold their heel and do it. But you do need to look over that procedure on 10.2. That is on page 370 to 373 in the book. Capillary blood gases. This is on figure 10.3, procedure 10.3. This is on 374 to 376 in your book. Look over these. We also won't do these in class, but you do need to be aware of how to do them. Neonatal bilirubin collection. Why do we need to do this? This is the main reason why babies in the NICU or the nursery get stuck a lot. So this is one test for sure that you need to know why they do it. Increased bilirubin on anybody can cause jaundice, but especially in our neonates and our babies. If they have overproduction of bilirubin, then they may have what is called hemolytic disease of the newborn. And so in this case, you need to be aware that they are going to be checking these bilirubins on these babies every day, if not within 2 times a day, checking to see if their bilirubin levels are coming down. If it is an adult or even a baby, well, let's go with baby here. It could be not just overproduction of bilirubin, maybe they have impaired excretion of their bilirubin, and that can happen from an immature liver, so a baby's immature liver. Either way, you do need to know those cause an increase in bilirubin and cause jaundice. So hemolytic disease of the newborn or immature liver, both of those cause increased bilirubin for different reasons. In hemolytic disease, they're having a bunch overproduction. In immature liver, they're having impaired excretion. They can't release it out good enough, and so it builds up in the blood. Problems with too much bilirubin is that bilirubin can cross the blood-brain barrier, and if you look on the next slide, you'll see the actual sickness that it causes. It is called kernicterus. Kernicterus is a brain dysfunction from toxic levels of bilirubin. And if these babies get toxic levels, then the doctors make the executive decision to give them a transfusion if their levels increase at a rate equal to or greater than 5 milligrams per deciliter per hour, or their blood level, just the level, exceeds 18 milligrams per deciliter. Okay, so they may need a transfusion in that case. If their levels are not quite that high, then they may just put the baby under light and use what they call phototherapy. This is where they do the Billy lights or the Billy blankets. And this means, this is trying to help the baby's body to break down the bilirubin. One thing you need to note on the caution on this slide, the light must be turned off when collecting a bilirubin specimen, because we want to get an accurate count of what their body has, and we don't want it to start breaking down bilirubin in the specimen as it's being collected, okay, because we want an accurate number. And so we would turn the light off or get the baby out of the Billy box when you're collecting the specimen. You are going to collect this specimen by a heel puncture. This is where you need to make sure and note too what color tube. It's going to be an amber colored microtainer. This amber colored microtainer protects it from light. If you don't have an amber colored microtainer, then you're going to need some tinfoil, because tinfoil will protect the specimen from light as well. If you want to see what an amber colored tube looks like, look on page 377 in your book. There is a figure 1013 that shows that amber colored tube. Okay, a new way is called a transcutaneous bilirubin. It's a TCB. So this is a test device that actually can test for this baby's bilirubin by directing a light into the skin on the infant's head or their sternum. And what it does is it measures the intensity of the specific wavelength reflected back. And so what this does, this transcutaneous, keeps this baby from having to get so many sticks. If you look on page 377, you will see a key point. This discusses this transcutaneous bilirubin. It is a point of care device, so you can do it right there at the baby's bedside. And this allows you to check for hyperbilirubinemia. Remember, hyper is high, hypo is low. So too much bilirubin is called hyperbilirubinemia. And there's no pain to the baby. The baby doesn't get stuck. You just put that light on them and it reads it. Okay, let's discuss newborn screening. This is the state-mandated testing of newborns to identify rare but serious health conditions that can be present at birth, even though affected infants may not show symptoms of them at first. So if you get a positive test, what that means is there's further testing that needs to be done. But there's 3 parts to this test. You've first got a blood spot screening. You also have a pulse oximetry and a hearing test. These are all 3 done. So on this, there is a recommended uniform panel, and it's called an RUSP. What this does is detect 36 disorders which have effective treatments. Most states screen this particular panel, but some states can screen up to 60 disorders instead of 36. But if you look right above that where it's talking about the state mandated, it detects rare, serious, inherited, metabolic, hormonal, and even functional conditions that can cause severe mental handicaps and other problems if you don't detect them and treat them early. So this is a good thing, because if you find out the baby has it, usually you can give them a way better outcome on life, knowing ahead of time and knowing how to treat it early. So the timing is very important on these tests. The infant needs to be somewhere between 24 and 72 hours old. You don't want it to be too old, but you can give it just a little while and let it be born like a day. Don't give it, 2 hours. Some of the common tests that are done in all 50 states and the U.S. territories are the test for fetal ketonuria, and we will discuss these on the next slide, hypothyroidism, galactosemia, and cystic fibrosis. So let's first talk about phenylketonuria, which is PKU. This is where the baby has a defect in the enzyme that breaks down phenylalanine. There is no cure for this, but if you know this when the baby's like a day old, you can treat it with a special diet, and it would be on that special diet for the rest of its life. But it is a fairly easy fix if you check it early without it going into the possibilities of problems that come with not diagnosing them early. Hypothyroidism, remember hypo is low, so this means they have insufficient or low levels of their thyroid hormone. This also detects non-inherited forms. Positive results are confirmed by running a TSH. So they want to see if the TSH is the thyroid stimulating hormone. So if their thyroid hormone is low, they want to know if, maybe is the problem with the thyroid stimulating hormone? So in that case, the actual thyroid they're checking at the beginning is T4. That's thyroxine. So if they have a problem with that, they confirm it by then measuring TSH. And this is treatable. You treat it by supplying the missing thyroid hormone orally, and you give it to them every day for the rest of their life, okay? So the incidence of hypothyroidism in the U.S. is 5 out of 100 people, ages 12 and older, have this. Okay, galactosemia. This means they have the missing enzyme that metabolizes galactose or milk sugar, and you treat it by removing all milk products. But what happens if you don't do it? If they lack the enzyme to convert the milk sugar galactose into glucose that's needed by the body, then within a week, an infant that has this will have failure to thrive because they'll start having anorexia, diarrhea, vomiting, unless galactose and lactose are removed from their diet. So basically, even though you're feeding them, the infant may starve to death if you don't treat it. They also will have failure to grow, they could be mentally handicapped, and even have cataracts. So treatment is easy though, just remove all milk and dairy products from their diet. The incident rate is 1 in 60,000 live births have this. The last one here is cystic fibrosis. This is a genetic disorder caused by one or more mutations in the gene that directs a protein responsible for regulating the transport of chloride across cell membranes. So cystic fibrosis involves multiple organs, but the main organs are the lungs and the pancreas. What happens is the mutation causes the body to produce this thick, sticky mucus that builds up in the lungs and other organs. This mucus obstructs the passageways in the lungs, and this leads to pulmonary or lung infections. And then mucus blockage of the pancreatic enzymes that you have to digest food, that can lead to malnutrition. So if you learn that they have this early, treatment can help avoid respiratory distress and malnutrition in these babies and also increase their life expectancy. It is estimated that 1 out of 3,200 live births among white people have this, 1 in 4,000 to 10,000 among Hispanics, and 1 in 17,000 among black people, and 1 in 31,000 in Asian and Native American infants. Another unique thing, if you look on the last note there, it says patients' sweat tastes very salty in cystic fibrosis patients. Okay, I want you to look at how they do this newborn screening. This is the blood spot collection. There is a picture of this baby, a bigger picture of 1015 on page 380. But there's an actual picture of the specimen screening form on 1014 in your book on 379. Okay, so that's just kind of showing you. But these blood spot tests are performed on a few drops of blood obtained by a heel puncture. The blood drops are collected by absorption onto those circles. Do you see those circles by that baby's heel? Onto those circles printed on a special type of filter paper. The blood-filled circles are called blood spots, and you can do as many as 80 different disorders in those blood spots on one form. If they end up giving this baby a transfusion, then you need to do this before they start the transfusion, because then you'll have dilution of the sample with the donor blood, and then you're not going to get accurate results. So this needs to be before the newborn gets a transfusion. But each circle needs to be completely filled with one large free-flowing drop for each circle applied to the side of the filter paper. You don't touch the filter paper to the surface of their heel. The drop should soak through the circle and completely fill the other side. You continue it until the circles are all filled. Any unfilled or incompletely filled circles will have the inability to do all the exact tests on that particular circle. So take great care to fill the circles. You only do one side and one drop per circle. Okay, look at the caution in your book on page 380. Do not contaminate the filter paper circles by touching them with or without gloves, or allowing any other object or substance to touch them before, during, or after collection. Substances that have been identified as contaminants in newborn screenings include alcohol, like not letting their heel dry, formula, lotion, powder, and urine. And these are things that got on the paper before they put the blood spot. So they know if something's on there that shouldn't be. And you want to make sure that you don't contaminate that. After it's collected, the specimen must be allowed to air dry in an elevated horizontal position away from heat or sunlight. They must not be hung to dry or stacked together. When they're dry, the requisition containing the sample is normally placed in a special envelope and sent to state public health labs or other approved labs for testing. And then the results are then sent to the infant's physician or another healthcare provider. This is just your picture of your routine blood film smear prep. So a blood film or smear is a drop of blood that's spread thin on a microscope slide, okay? So this is how you do a manual diff. In this case, you are going to send this to the lab after it's done, and then they will be able to identify the blood cells. This actual procedure is on 1015. It is on page 383 in your book. So this is the steps. You're going to perform the capillary puncture just like you do, wipe it with alcohol, stick them. Then you're going to wipe away the first drop, again exactly the same as a regular capillary. But then the second drop, you're going to touch a slide to the next drop that forms. Okay, so we're going to touch it to the slide. The drop needs to be 1 to 2 millimeters in diameter and centered on the slide adjacent to the frosted end. Then you're going to hold the blood drop slide between your thumb and forefinger of your non-dominant hand, or between the thumb and index finger pointing away from you. And with the other hand, you're going to rest the second slide in front of the drop at an angle of about 30 degrees. This second slide is called the pusher or the spreader slide, and it is held at one end between the thumb and index finger in a vertical or horizontal position. If the blood is normal thickness, if it's not real runny like they're not on blood thinners, then a 30-degree angle will create a smear that covers about 3/4 of the remaining area of the slide. So you're going to take it, pull the spreader back to the edge of the blood drop. You're going to stop it as soon as it touches the drop and allow the blood to spread along the width. See, that drop turned into a straight line then. The pusher slide, you're going to have a bullet-shaped film once you do this. You're going to push the spreader slide from the drop in one smooth motion, carrying it the entire length. Do you see it in that last picture? The entire length and off the end of the blood drop slide. Okay, you're going to let the weight of the spreader carry the blood, and this is what creates the smear. Do not push down on the spreader because this is going to create lines and ridges, and then they can't do that blood smear. You're going to place the drop of blood for the second smear on the spreader slide. Use the slide with the first smear as the spreader slide for the second smear and make it the same manner as the first one. This way 2 smears can be made using only 2 slides. Okay? So you're going to spread the blood out with one, then you're going to flip it over and do the other one. You're going to place gauze over the site after you make your 2 slides and apply pressure if it's a young child or an infant. If the patient is an older child or an adult, you're going to ask them to apply pressure. You're then going to label the frosted slide by writing the patient information in pencil on the frosted area. Don't use ink because it can dissolve. If you've got a label already, you're just going to attach it over the writing or in the empty space at the blood drop end of the slide. You're going to verify the labeling, make sure the patient's ID band matches, allow the blood films to dry in the air, place them in a secondary container for transport. Just like you don't blow on their fingers or their arm, you never blow on a slide to dry it because blood cell distortion can result. You can spread out the cells and make it not be accurate. Also, you need to be aware that any unfixed slides, meaning that they are not dry or not ready, any unfixed slides that don't have a fixative on them or a cover, then this means they are capable of transmitting disease and you're going to handle them accordingly. Before you leave the patient, check their puncture site, apply the Band-Aid, discard the materials, thank the patient or the guardian of the baby, remove your gloves, sanitize your hands, and take it back to the lab. Okay, that was a thin blood smear. Let's talk about the difference. A thick blood smear. These are most often requested. You need to know test-wise. Why do they ask for a thick one? A thick one is used for typically looking for malaria. This is a type of parasite. The organism is called a plasmodia, and they're transmitted to humans by the bite of an infected female Anopheles mosquito. Symptoms of malaria, you'll have fever and chills at regular intervals, and then these organisms are spreading while this is happening, and they're spreading inside red cells. So this can cause a type of anemia. So to do this, we are going to diagnose them, or the doctor will, by the presence of seeing the organism in the peripheral blood smear. So they got to have a big drop, okay? They want a big one to be able to see it. Some species can be found in a regular blood smear, but some need the thick one. So these may be ordered stat or at timed intervals and are most commonly collected just before the onset of fever and chills. Because if the patient comes in and they've had fever and chills, usually it comes in waves. Like they'll get fever, it goes away. Fever again, it goes away. So this collection is done between those bouts of fever. To prepare a thick smear, you want a very large drop of blood. in the center of the glass slide, not just a little one, but a very large drop, and spread it with the corner of another slide or cover slip until it is the size of a dime. The smear needs to be able to dry for a minimum of 2 hours before they stain it. Then you stain it with what we call a Giemsa stain, which is a water-based stain, and this lyses the red blood cells and makes the organisms easier to see. So this is different. You're going to spread it out with the corner, make it the size of a dime, then they're going to stain it in the lab, and this allows you to be able to see if they have malaria in those slides, but you need to dry it for 2 hours. And this concludes the end of our Chapter 10 PowerPoint and lecture. This is some entry-level competencies that you should have learned in this chapter. You can look over these. These are very similar to the objectives that were at the front. I will leave time during class for any questions, or I will leave a discussion board if you have any questions and want to put them there, and we can discuss them before class. Thanks for joining me, and I will see you next week.